Thank you everyone for joining us tonight for our two-part series on the brainwaves for EEG, TMS, and qEEG. Tonight is part 1, and we will be covering EEG and TMS fundamentals to help you become more familiar and hopefully help you in your practice. But first, we want to give a brief hello from our iMediSync North America team. Feel free to screenshot this and save our emails or follow us on LinkedIn. We're more than happy to answer any questions you have or to respond to any feedback. If there's certain content we can create to help support you, we would love to hear about it. A little bit about iMediSync is we are a one-stop shop. We offer software to create reports, to analyze the data. We have a beautiful normative database that compares gender and age specific. Our hardware is able to collect EEGs and do HRV analysis, as well as transcranial photobiomodulation, also known as near-infrared LED care, and another intervention of neurofeedback, kind of a 4-in-1 approach to offer everything you need to help you with your practice. A huge shout out to our co-sponsors, Rastreal Brazil. They're a master distributor in Brazil with experts in implementing strategies and highly complex technologies. And as I like to say, anything they touch is golden. They just have this high level of professionalism, and we're very happy to be associated with them. Our moderator for this evening is Dr. Bruno Pessoa. He's a neurosurgeon and researcher. He currently is conducting several studies on qEEG and AI, specifically applied to Parkinson's disease and chronic pain. And on a personal note, I was at an Alzheimer's conference and everyone from Brazil, I'm like, do you know Dr. Bruno? And most of them were like, yes, we love him. We listen to his lectures. So we're really blessed to have such a bright mind with us. And with that, I'll turn it over to you, Dr. Bruno, to introduce our topic and our speakers for tonight.
Thank you so much, Rebecca, Rastreal, iMediSync, for this opportunity to bring together two experts in this subject, Cory Williams and Shari Johannson. So it's a great pleasure for us in Brazil to get to know this topic, this subject about TMS, transcranial magnetic stimulation, and qEEG as well. So Cory Williams has been working with EEG since 2015. He's currently is the director of neurodiagnostics for Nashville Child and Family Wellness Center. He has experience of qEEG analysis as well, neurofeedback in TMS. And Shari Johannson, she has a huge experience as well with EEG. She has been working for more than 12 years with EEG itself, and over 3 decades as consulting experience and serving as well with a mentor and training people all over the place, not only in the US, but outside the US as well. So it's a great pleasure for us in Brazil, and thank you so much. And without any further ado, I'd like to invite Cory Williams to speak about TMS and qEEG for us. Thank you.
Thank you, sir. Much appreciated. On the financial disclosure side, I don't work for iMediSync. I work in Nashville, so just wanted to be clear on that part. I'm not a rep from the company. That's Miss Rebecca. So if you have specific questions, you can direct those to her. So we're going to take a look at some learning targets for today, some stuff that I hope you all are able to take away from this presentation. And in proper teacher format, we've got these in I language, so I can describe the basic fundamentals of TMS and of EEG, and I can explain a qEEG assessment in simple layman's terms. Next time, we're going to get into some clinical applications and go through some case studies. So definitely tune in next time. I think Shari's going to lead that one, and so you're going to get some really awesome stuff if you make it to that one too. And then one last note before we get into all the information. I talk fast. Sorry. Also, if you have questions, because we're recording this, please save your questions to the end. So we're going to cover a ton of information as you're watching, as you're listening. jot stuff down and then throw the questions at us at the end, and we'll be happy to get to them, okay? But throughout the recording, we'd ask that you just, hold on to those. So off we go. Let's talk about TMS, or transcranial magnetic stimulation. So the first thing I wanted to do here was just give a little bit of an overview of kind of from the most invasive type of brain intervention we have to the least invasive. So when we talk about most invasive, right, the thing that goes most into you, brain surgery is the highest. And as we continue down this path, you'll see that transcranial magnetic stimulation is right in the middle. So it is putting energy into the brain, but it's not invasive from like a surgical perspective. So it gets that spot right in the middle. And that's what we're going to talk about, just the very basics today. Okay. So this is kind of what a TMS setup would look like if you added one to your office, although this isn't the only way to do it. But typically the client or the patient gets a coil that's placed over their head. And this coil uses magnetic fields to target specific aspects of brain function. The coil plugs into the TMS sort of power unit here, and there's usually a computer displaying output of some kind here. Different coils are shaped differently. This one here is a figure 8, as you can see, because it's shaped like an 8. But there are other types too, depending on the different producers and manufacturers. Typically, TMS is used to target the left dorsolateral prefrontal cortex. And we'll get into that here. It's a treatment for, at least in the US and the FDA, it's been approved for depression. So in the 80s, Dr. Barker and his team first came up with the idea for TMS. They were trying to create some imaging technology, and it quickly moved from an assessment tool to a treatment tool. By the early 2000s, they'd moved into sort of clinical use of this tool. And in 2008, it was approved by the FDA for the treatment of depression. Since then, it's been also approved for the treatment of migraines, OCD, smoking, and anxiety when comorbid with depression. But depression is the big one. There's a ton of research on the use of TMS in the treatment of depression. So a little bit on the logistics of this. When clients come in, they're typically in the office for about 20 minutes receiving the treatment. And this is a little bit dependent on frequency, but the coil will pulse magnetic energy roughly 3,000 times. Most TMS protocols consist of 36 sessions. The first 30 are done relatively intensely. We ask our clients to come in every day for 30 days, business days. We take weekends off. And then there's a slow wind down afterwards. And so this means that over the course of a TMS treatment protocol, 36 sessions, 3,000 pulses per session, we're getting 10,000 pulses or more. So that coil that we showed you the picture of earlier is placed on the scalp. It touches the head and it passes a small magnetic pulse through the skull. You can feel it when the machine activates. You feel the pulse on your head like a tap. That magnetic pulse causes changes in the electrical fields of pyramidal neurons. So those are neurons that are perpendicular to the skull. Those are the neurons that are being most targeted for activation or inhibition, depending on the type of pulse that you're using. And that means that we can turn parts of the brain on, or we can slow them down or turn them off, depending on what the client needs. Now, like I said, a lot of the time we target the left dorsolateral prefrontal cortex. That's the kind of primary target in cases of depression. But what we know about the brain is that it works in large-scale networks. And these are some of the networks, this isn't even all of them, but these are some of the networks that include this area of the brain. So you can see there's cognitive control, the default mode network, so what we use when we're thinking quietly to ourselves, the salience network, which helps us to figure out what we should and shouldn't pay attention to. Frontal parietal network is important for executive function. the cognitive affective network, so how we regulate our own emotions, and the reward network, which plays a role in depression. So all of these major networks involve this part of the brain to some extent, which is why we often see improvements across a whole host of symptoms, even when we're targeting just depression. And so I wanted to show you, this is a model of what network hubs looks like in the brain. So you've got some areas, these filled in blue circles, that are hubs. And you can see some of them are hubs for multiple networks, and some are hubs for isolated networks. So there's a lot of overlap. And these are some of the networks, again, that get kind of trained when we do TMS. So even though we're targeting that left dorsolateral prefrontal cortex, all of these areas have been shown to exhibit change after TMS sessions. And for those of you who are well-versed in neuroanatomy, you're going to recognize some really important parts of the brain here, right? The anterior cingulate, which is the hub of executive function, the amygdala, which is the threat detection center, the hippocampus for memory, the motor cortex, the posterior cingulate and the insula, which are involved in introception and emotional processes. So a lot of different areas of the brain will get change from a TMS session, even though it's targeting one small area specifically. So that's a very quick overview of kind of what is TMS, right? It's a way to energize or inhibit parts of the brain. But what we want to know then is, what parts of the brain should we target? Because, you know, the FDA has approved this for the treatment of depression at the left dorsolateral prefrontal cortex, but some people might have issues with other aspects of brain function. So a great way to figure out what part of the brain should we target, whether that's with TMS or any other intervention, we can use a qEEG assessment. Now, there are some research studies that use fMRI to find their training targets or their treatment targets. The problem with fMRI is that it's really expensive and you don't have one in your office. What's really cool about EEG or qEEG is that it's easily portable and it's not nearly as expensive as an fMRI machine. So what is a qEEG assessment? Well, EEG stands for electroencephalogram. That measures the brain's electrical activity. So when we put the Q in front of it, the qEEG, that means that after we measure the brain's electrical activity, we analyze it quantitatively. So we put some electrodes to do this, to get this recording. We put some electrodes on the scalp, and those electrodes measure the activity of pyramidal neurons that are perpendicular to the skull. In this particular image, you see one of the iMediSync helmets, and inside of this helmet are some sensors, and those sensors are what's going to record the EEG data. That data is then analyzed. We can compare it to age-referenced normative databases, and those results are really useful because they help us to plan out individual treatment plans. They help us to make treatments specific to the individual, whether we're doing neurofeedback or whether we're doing TMS, photobiomodulation. We're able to better target once we understand what brain function looks like. So in a qEEG assessment, we're going to end up with a visual inspection of data, a spectral analysis of peaks, and then 2- and 3-dimensional images that show more specific targeting. And I'm going to walk through each of those pieces, so don't feel bad if you don't really understand what all that means yet, because that part's coming. But I wanted to kind of give, just before we even get into the specifics, why this is so helpful. I couldn't imagine running, I work in mental health, I could not imagine running this clinic without looking at brain data. We use it to identify training targets or treatment targets. We use it to help distinguish between whether symptoms are caused by neurological dysregulation or cognitive issues, right? And as you all know, I'm sure, the thought process is an important piece to all this. For some folks, they need help with the brain and the thinking patterns. For some people, it's one or the other. And so the EEG can help us to figure that out. The EEG is also a really useful tool for helping to guide medication choices. Now, it's never an exact one-to-one, oh, this EEG means this medication. It's not that simple, but it is a helpful tool in kind of directing what type of medication choices we might think about. And again, a way to think about this is this a fast brain or a slow brain, right? And that can really help to kind of parse down quickly what kind of medication might be most beneficial. For the clients, why clients like to have an EEG? Well, one is that it helps them to kind of understand the role of biology and how they feel, right? If we think about things from a biopsychosocial model, this is a way to visualize what the biology looks like. It can offer some perspective on severity by comparing to a normative database. We can tell a client, this activity is 3 standard deviations outside the norm. That's a lot. Or actually, this is pretty close to normative. So, it's not a thing to worry about. And they can help us to track progress and change over time. So if we do an EEG before treatment and an EEG post-treatment, that helps us to kind of measure, hey, look, we recommended this intervention, and you can see very specifically how it helped. So for hardware, and there's a lot of different choices out there. iMediSync makes these helmets that are really fantastic. These are what the sensors look like, nice up and close. And those sensors are going to measure the brain's electrical activity. Once you have measured that activity, then you want to run it through some type of processing software. And you can see on the left-hand side, we get a look at what different conditions might look like, healthy versus depressed versus Alzheimer's. On the right-hand side, you can see what happens when we run an individual's data set through some sort of discriminant function. So this is useful for clients who are aging. There's a discriminant function for head injuries. There's one for learning difficulties. So there's a lot of different tools that you can use to be able to inform a client about what their brain function means for them. Now, when we look at EEG, and some of you may already know this stuff, and if you do, you're welcome for the review, and if you don't, you're welcome for the new information. When we measure EEG, we group waves together based on their function. So what do these waves do? What's their primary function? The slowest is called delta. That's typically 1 to 4 hertz. And a hertz, in case you're curious, hertz are measured in cycles per second. So how many times does that wave go up and down in 1 second? Theta is a little bit faster in the 4 to 8 hertz range. Theta is often used when we are kind of daydreaming or in deep thought. We've got alpha, which is 8 to 13. Some people will say 8 to 12. It's a little bit more relaxed. We're not concentrating hard. It's more of a passive attention. Beta states go from 13 to 30. It's a little bit of a broader band, and it's more alert, more active thinking, more concentration. And then gamma, which goes in the kind of 30, 40, sometimes even up to 50 range, can be indicative of disorders, like, for example, schizophrenia. But gamma also occurs when we have aha moments. So when our brain is learning something new and we are internalizing that knowledge, our brain should burst little bits of gamma. Also, gamma is present when we bind networks together, when we need to kind of cross-task. But that's really complex stuff. For the most part, the thing to take away here is that there are different wavelengths, and we classify them by their speed and by what they do. So I'm sure all of you are ready for this level of mathematics. In fact, I'm joking. I don't even know how to read this. This is really complex math. But what's awesome here is this picture to the right. So this line at the very top of this picture, this line that kind of goes up and down and dips and it looks sort of jagged, that line represents a raw EEG signal, right? What we would get from one sensor placed on someone's head. When we take that signal, that raw signal, we run it through what's called a fast Fourier transform. This is the mathematical equation for it. Thankfully, we can put away the pens and paper and abacus and let the computer do it for us. And after it goes through the fast Fourier transform, then we get a breakdown of component signals. So on the right here, you can see there is some delta activity in this signal. There is some slightly faster, what I would say looks like theta, and then some beta activity. And all three of them happen simultaneously to create the composite raw EEG signal. So we use that Fourier transform to break the signal apart into pieces, and that's how we go about analyzing the data. When we analyze that data, there are 4 kind of steps that we go through. There's a visual inspection, a spectral analysis, a 2-dimensional analysis, and a 3-dimensional analysis. Now, I could talk for probably an hour on each one of these things. I'm not going to. You're welcome, or I'm sorry. You can take whichever you want. But I am going to touch on each one briefly, just so you can get a quick look at what does this mean, what does this do, how do we use it. So when we look at EEG, and this goes back to kind of the origins of EEG and how it's used currently in the medication, or in the medical world, it's often used to detect serious issues with brain function. So things like seizures or stroke or head injury. And a lot of the time, we don't get to see that stuff unless we look at a raw signal. The raw signal also helps us to cut out what's called artifact. So when you record an EEG, you'll get a lot of noise in your signal that is not from the brain. Things like eye blinks, things like muscle, and we don't want to map an eye blink or a muscle movement and interpret it as if it is real brain function. The other reason that we want to look at raw data is because the morphology, right, how the waves are shaped, can be an important thing. There are some types of EEG activity, such as mu rhythm, in which the morphology matters a great deal. How the waves are shaped influences how the client perceives the world. And so looking at the raw data is the only way to see that. It also helps us to make medication predictions. And typically when we do this, we look across multiple montages or ways of organizing the data so we can kind of see it from different angles, so that we can be very confident in what it is that we're seeing. Now, as I just mentioned, one of the things that we'll sometimes see in an EEG is something that requires a referral to neurology. So say, for example, an epileptiform discharge. Right? I'm not a neurologist. I don't diagnose seizures. But if I see something like this sort of spike and slow wave, I know that this is potentially indicative of a seizure disorder. And I want to send this patient to a neurologist to make sure that their brain is healthy. We do know that these types of discharges are more common in the ADHD population, about 30%. They're very common in the autism population, about 60%, although if you do a sleep study, that number goes up to 85%, and they are less common in the mood disorders or depressive folks. So looking at this raw signal helps us to kind of figure out some diagnostic criteria, but also, do we need to send this person for a neurological workup? And then these are 2-dimensional maps here, and I'm skipping ahead a little bit because I wanted to show you what we see is a high beta, right? This is 21 hertz to 25. This is 26 to 30. And 2 different people, 2 different clients, the maps look similar, right? These look like fast brains. 21 to 30 hertz is a fast frequency. This is a high level of activation. Okay, so they almost look identical, lots of fast stuff. But when we look at the raw signal, the one on the left shows us cortical beta activity. That's beta coming from the brain. It's known as excessive spindling beta. It's common in oppositional defiance. It's common in sleep disorders, insomnia, in scattered focus, attention, anxiety. It's a pathological presentation. In the right, what we have is just muscle artifact. It's a lot of muscle tension. It's a person who can't relax their forehead. So I'm going to go back one slide so you can see these maps look similar, but their brains look very different. And we don't get to know that unless we look at the raw data first. So it's a really important step when we do these EEG assessments for our clients. Like I said, we can look at different montages. So this is the same brain, the same time signature in 3 different montages. And each one gives you different information. Now, we don't need to get into the specifics of why one versus the other. I mean, this would take us, this is a class in and of itself, but just know that there are different ways that we can organize the data, and each way that we organize it shows us a little bit more information, tells us a little bit more about the brain. And that's what we want. That's why we do these assessments, so that we can learn as much as we can about how our client's brain is functioning. Then, after we've done that, after we've got that raw inspection of data, we create maps. And these maps will show us where activity is the highest. So absolute power, which is what we see here, measures how much energy the brain is producing in a given bandwidth in a given sensor location. So you can see this is broken down by bandwidth, delta, theta, alpha, beta, but also we're seeing on the head, where is this activity most common or most prevalent? And the answer looks like kind of the right posterior in each of these. We typically measure this in microvolts squared, and we can use this to compare to z-scored databases, which will help us to kind of figure out how deviant is this activity from a normative measure. So this is the first part of the 2-dimensional maps, the absolute power maps. We also get to look at what are called relative power maps. And these show us a percentage of the whole. What percent of all of the activity is in a given frequency bandwidth at a sensor location? So instead of comparing to a database, although we can compare this to databases, this is a little bit more individual specific. It tells us within an individual brain, what do the power ratios look like? Is there activity that's more prevalent than others? And what we'll see here is this person's got some slowing in the delta and theta range, and a little bit in the beta range at C4 as well. Their alpha production looks lower, right? And that's for this individual. Oh, sorry. Okay, now we take that data and we can run it through a normative database, which will give us z-scores on how outside of the norm a given activity bandwidth is. Now, there's a lot to be said about what is, quote unquote normal. What do normative values look like? How do we construct a database? Again, really complex topic, and we could talk for probably an hour on just database construction. What I tell my clients to focus on is when we have activity that would be outside of the norm in any database, no matter what we considered normal. So we'll see a client who has 2 or 3 standard deviations above the norm or below the norm. Well, that's going to be outside of the norm in just about any database, regardless of the N. And that's kind of what we focus our treatment on, or focus our treatment goals on, is that really aberrant activity. We can also look at a spectral analysis. Now, this is from the iMediSync software. And what you can see here is where activity is peaking and where it's highest in a given frequency range at a given sensor. So looking at this head, we can see at FZ, the alpha is higher than in all the surrounding sensors. And high alpha in FZ can be a marker for depression or OCD or anxiety. Shari will talk more about clinical presentation, but that's a thing that's helpful for us as clinicians to know. And when we're able to combine that with our knowledge about a client, okay, so this could be an OCD profile or a depression profile. Well, we know that this person doesn't have OCD. Great, let's ask them some mood questions, because that might be a depression marker. Also, we'll see that the depression is the alpha is a little bit higher in the left hemisphere in FP1 and F3. So that's the area that we would target with TMS, that left dorsolateral prefrontal cortex. I would guess that this is probably a depression case, if I had to guess. Another thing that we get to look at when we compress all this data is connectivity. And so what you'll see in this spiral, and I know it's kind of a lot to take in visually at first, what you get to see in this spiral are different parts of the brain. In the left hemisphere on the left, the right hemisphere on the right. And you'll see lines between them that are either blue or red. The blue lines are going to tell us areas that are not connecting well with each other. The red lines are going to tell us areas that are over-connected. And that's another thing that we can address with different interventions, different medications, different types of training. But it helps us to figure out, again, what's happening in this brain and what are we going to do about it. Now, obviously, the brain is a three-dimensional thing, so we want to look at it in 3 dimensions, right? And to do that, we use something called low-resolution topographical analysis, or LORETA. It's a fancy acronym, and it gives us spatial resolution of about 7 cubic millimeters. Some technology might be able to get a little bit more advanced to that. The big thing to know about LORETA imaging is that the spatial resolution compared to an fMRI is not as good, but the temporal resolution, how much lag is there between brain activity and what you see, is much, much higher in an EEG or a LORETA reading than it is in an MRI reading. In an fMRI machine, you'll sometimes have a lag of minutes, but not in LORETA. And it is based on a few key assumptions. We assume that the brain is shaped correctly. We assume that the data on the surface is accurate, some of those types of things. And if we put all of this together, right, the raw analysis, the spectral analysis, the LORETA analysis, we get what's called independent component analysis. And it's really cool that iMediSync will let you do this. Not every piece of software will. What we have here is the raw EEG signal on top. We get to see what is that signal broken down on the frequency spectrum. It's primarily alpha. Where does it occur in the brain? And 3-dimensionally, where does it occur? So this is looking at one component that's made up of multiple rhythms in a 3-dimensional shape. So this is, as far as I'm concerned, about as advanced as you can get when it comes to trying to analyze what is happening in a brain in real time. Okay, and so with all of that said, I'm going to turn this over to our other presenter, Shari. She's fantastic, and she's going to talk a little bit about how we can use this when we're talking with clients, the sort of clinical utility of using this EEG stuff. So, Shari, you ready?
Yep, awesome. Thank you, Cory.
Fantastic.
I'm hoping, okay, you're going to take care of the slides for me, so that's great.
I gotcha.
Awesome. So, basically when you're talking to clients, I'm a therapist, so I'm going to talk to them about the story their EEG is telling me. And the EEG does tell us a story. It's going to tell us whether they're fast or slow, what type of activity, where does it occur, because those Brodmann areas that Cory was talking about, that show up on your iSync report, each of those areas, each of the networks is responsible for a different type of processing. So by looking at the EEG, we can narrow down where the problem is coming from. He was talking about the one that he showed on the spectral that had the little Charlie Brown head on it. And because it had alpha in the front skewed to left, it is a good guess to say that there is negative rumination and depression there. So that's one way the clinical utility of the EEG can help us match and confirm diagnosis and match what's going on in the brain with the client's symptoms. So what's awesome about EEG is when we do all of this analysis and we're thinking in layers, we're thinking, hey, what's the chief complaint of the client? What do I see in the raw EEG? What do I see, outside that normative database comparison? What do I see in the Brodmann areas? What networks do I tap into? By thinking in layers with all of those, we can come up with a good list, narrowing in on this is a functional reason why your client has this presentation. And that's the beauty of EEG work. And so, being able to compile that information and come back to your client and say, hey, there is a functional, measurable reason why your memory is not so good, and your verbal fluency and word finding is not as fast as it used to be. You're dropping your words. That's because this area processes that, right? And you have a slow wave there or a dysfunction there. So that's the story that the EEG is able to tell us. And we can look at overall activity processing speed, which is kind of your sampling rate of the world. And so different waves give us different type of processing. And we know, I'll go over this more in our second webinar, but we know that slow waves should be in certain places during certain, obviously bigger during sleep, and stay in the back of the head during processing and task-oriented activities. You can go to the next slide. So an example of a normal EEG, these would be the FFTs, and we would have, in an eyes open situation, we would have alpha, which is represented here by the red, bigger in the back of the head and getting smaller as we move towards the front. And we call this the anterior-posterior gradient. So slow waves bigger in the back, especially in that triangle that is outlined with the dotted line, the PZ0102, and getting smaller as we move forward. Betas should be largest in the front, in the eyes open, especially on task, and get smaller as it moves towards the back. Also, because 85% of the information coming to our brain is coming through our visual system, if we're a sighted person, when we close our eyes, a lot of that goes away, and betas, on-task betas, should calm down, and slow waves should kind of take over because we're going to an internal focus into a calm state. And so that's one way that the anterior-posterior gradient can help us know if things are in line or not in line with what we expect. So this would be an example of an excess beta in the front left. So most people think of major depressive disorder being alpha asymmetry to the left, but there are many presentations, and this is why the EEG is so important. You come in for TMS or neurofeedback or medications or whatever your treatment is, complaining of depression, and maybe you don't have asymmetry to the left in alpha. Maybe you have a beta at the left side, and that would be more of an agitated or irritable type of depression, burnout type of depression. So looking at the EEG is very important, not just for the diagnosis, but how are we going to intervene? Which medications are going to work? If you gave this a clinical case that is represented by this slide, an antidepressant, it would be ineffective because SSRI antidepressants lower frontal alpha, but they actually exacerbate beta. So you would have a bad reaction to your medication. This person would do much better on a guanfacine or GABAergic medication, something like that. But TMS and neurofeedback, and there are lots, PBM, there are lots of interventions that we'll talk about in 2 weeks that can be done for this client. All right. Do you want to take back over, Cory?
Sure, yeah. So, and feel free to chime in. I mean,
Sure.
Obviously, we appreciate all your knowledge. I put in a few kind of last notes here that the brain works in these really big and dynamic networks. And because of that, when we see dysregulation in one specific area, it may not disrupt the entire network. It might, it absolutely can, but sometimes the rest of the network can pick up the slack, so to speak. And so sometimes, when we're looking at an EEG, we might say, this is a marker for depression. And the person will say, well, I've never been depressed before. And I'll say, well, that's great. Congratulations. It doesn't mean that you have depression. It means that potentially you could, given the right set of circumstances and depending on how the rest of that network works. Another thing, and this was really hard for me to wrap my head around when I first entered the field, is that a brain can be overactive and underactive at the same time. We can see fast and slow activity simultaneously in the same location. And the way I kind of describe this to clients is that you've got a car that can drive in the neighborhood or on the highway, but has nothing in the middle. And it's great when you need to park, and it's great when you need to go fast, but sometimes we just have to drive at like not a breakneck speed. And so for that, this brain is sort of struggling. We can only go slow or fast. I've heard it described as speeding with your foot on the accelerator and your foot on the brake at the same time.
Right. I drive a standard vehicle, a stick shift. And so you literally can be revving your engine and going nowhere.
There you go. That's great.
Same
right?
analogy, Cory.
Yeah,
That's great.
Exactly. And so that one took me a little bit of time to understand. And so sometimes we have to kind of explain that or walk through that with clients. And then the other piece here, and Shari, your background in therapy, I'm sure you can speak more to this, but I always try to explain things through the biopsychosocial model, right? And that means that biology, what your brain does, plays a really important role in how you feel, but also your psychology, what your mind is doing, how you think about things, your skills, your strategies, that plays a big role. And then also what's happening around you plays a role in how you feel, right? None of us are immune to the environment around us. And so when we look at someone's EEG, we get to talk about what the biology looks like and how that's impacting the situation. And I see tons of clients who say, look, I've done therapy for years and it hasn't helped. Well, that's because they're really focused on the middle piece of this, the psychodynamic piece, or maybe they're really focused on the environmental piece with their therapy. But if we haven't touched the biology yet, they may not be seeing progress.
I agree 100%. Because I've been a therapist for decades, probably as long as you've been around, Cory, it's important. I tell people, we can intervene to change your biology or change your brain, but you have to change your mind. Because if we take somebody who is in, let's say they come in with PTSD, and we get that all corrected, but they go back into a relationship of domestic violence, and the environment doesn't change, and they're not willing to step out of that, we're going to be back where we started from. So yes, it is very important that we see it through all of these lenses, or all of these ways of looking at the entire person, not just their brain. Every EEG belongs to a person, and they have a story. And so we need to match that EEG story with their story and regard them as a whole person.
Yeah, I love that. Every EEG belongs to a person. Absolutely. Yep. Well, that's where EEGs come from. 100%.
That's right.
Cool. So, yeah, we touched on this a little bit, but give us a little sneak preview. What do we got coming down the pipeline?
Yeah, basically, we're going to go into more of the clinical utility and all the ways that EEG can benefit a practice, whether you're a psychiatrist or a neuroscientist or a surgeon or a therapist for that matter. There are plenty of uses. So we're going to talk about that. I'm going to also look at before and after EEGs so that we can talk about different interventions. And basically just dive a little bit deeper into the clinical utility so that everybody, the goal here is to get more people in the medical field and in mental health to start looking at the EEG. And because it gives us so much information. And luckily in my area, I've got very good relationships with both neurologists and psychiatrists who now sometimes if they have a treatment resistant client, they will send their client to me to get an EEG so that they can kind of get to the bottom of it. I also work with a lot of functional medicine doctors for the same reason. And so we've had great success on seizures caused by environmental factors such as mold or EMFs. And, discovering that's difficult. So the EEG can really help us.
Awesome. Thank you.
Thank you.
All right. Thanks so much, Cory and Shari, for this wealth of information. We just have our contact information for both Cory and Shari. If you need help implementing EEG specialists, they they offer that as part of their services. We also have our iMediSync representative, myself. He's reached out and contacted me, as well as Rastrial's team for contact. And I'm really excited for part 2 coming up, as part 1 was kind of like, what is EEG? What are the components that make up a qEEG? And part 2 is how we use it, how we can use it in application and in the practice.